Okay, our next speaker is from the same center, looking at childhood leukemia at Berkeley. She's Catherine Metayer. She's a physician who was trained in France and has a PhD. She's working as she received her PhD, from Tulane University in New Orleans, and focused her work there on occupational exposures related to hematopoietic cancers in adults. She was a visiting scientist at NCI in Bethesda in the Division of Epi and Genetics, and started looking at secondary cancers following treatment for primary cancers. And she's currently an associate adjunct at UC Berkeley. So Catherine's going to talk today about her work in the Circle group. Thanks.
So first off, I'd like to give a little bit of background about leukemia. I don't know how many of you know about childhood leukemia. This is the first cancer in children, as shown in this figure from the California Cancer Registry. And this is by far the most prevalent cancer, followed by brain tumors and other more rare cancer, solid cancers. This is striking here. However, leukemia in children is a very rare disease, so it still poses a lot of challenges to study in depth when you want to look at both environmental and genetic factors and methylation patterns. What is interesting to know in terms of the basic statistics is that when you look at leukemia overall in green, you can see that there's a peak of incidence at a very early age, from 2 to 4, and this is mostly driven by the acute lymphocytic leukemia. And so you have really this peak here when other type of cancers in children are more bimodal, with a peak at an early age, it slows down, and then it rises again. So really, that tells us that something is happening at a very early age, even during pregnancy or preconception, and those are the time window that we're going to be interested in. I'm just echoing what Joe was describing before on the top of being a rare disease. It's a heterogeneous disease, which increase our difficulty in terms of statistical power. I will just repeat that out of the most common molecular subtypes are the TEL, AML, and the hyperdiploidy among older children, when characteristics of the infant are very different in terms of the 11q23 MLL gene fusion. So what Joe hasn't talked about is that some of those characteristics have been identified not only at diagnosis when we obtain the pretreatment bone marrow and blood specimen, but they have been identified at birth. So that gives us some clue of what could be the sequence of exposure of adverse event that would lead eventually to childhood leukemia. It's worth noting that this gene fusion happens in many children, and not all of them will turn into developing childhood leukemia, but this is a first trigger that could be the initiating event to developing leukemia later on. So we go back to our favorite cartoon in terms of where do we want to focus our attention in order to understand what are the exposures that could occur at preconception, during pregnancy, and the early years of the child. There could be 2 steps of initiation and promotion, but I must say also that this cartoon should show that it could be initiation postnatal as a start. It's not excluded. This two-hit model has been well described by Greaves in UK, that really developed more into this need of more than one event in order to lead to leukemia. So I'd like to go now into what we're doing at the California Childhood Leukemia study, and Dr. Biphenyl is the principal investigator of that study that started back in 95, I guess, back in 95 when Pat initiated the study. It was groundbreaking at the time in terms of methodology. The recruitment of cases is what we call ultra-rapid case ascertainment. We're working directly with a network of hospitals. As soon as a child is being diagnosed with leukemia, we are being informed within 72 hours that allow us to receive very precious materials before the treatment is initiated, which is usually pretty fast. So we can obtain bone marrow and peripheral blood before leukemia, before treatment, and those specimens are precious to Joe, who is doing a lot of tumor biology analysis. But it tells you that we collected about 1,000 of cases over the course of 15 years. That's a long stretch. It takes a lot of patience and motivation from the hospitals and our team to get through that. We are now expanding. This is the region where we're working, the Bay Area and the Central Valley, and we're now expanding in the South California to boost our numbers a little bit quicker. We also accrued about 1,200 healthy control from the California birth registries. And as you know, because of California, our population is split into non-Hispanic and Hispanic, and we have about 47 of Hispanic children. So the main hypotheses were like any complex disease, like autism, like we heard. We want to understand, is there any association with environmental exposure at large? What would be the contribution of genetic markers and methylation markers? And because we are facing, I'm losing the laser each time, I don't know if I'm going too fast. Because it's a rare disease, the most efficient design are retrospective case control studies, where you start with the disease and you try to characterize what could have been the exposures, and this is very challenging. So we have put a lot of effort in trying to get at different angles to characterize the exposure. And that cartoon shows that, of course, with a case control design, we start with interviews with the families. I mean, they're still providing very useful information in terms of the timing of exposure. This is where we're going to get it. We have pretty extensive residential history, and we've done a lot of geocoded and GIS studies to try to understand any population attribute that could contribute to the disease. Todd yesterday talked about dust sampling, has a reservoir of possible persistent compound that could also inform us. And we also did an inventory of pesticide, and I will talk about that as well. And we are getting into more biomarker studies, but still very, very early stage at that point. So I'd like to talk about what we have found so far in terms of the main chemical that could be found in the house or used in the house. The first one is paint and solvent. Again, we are asking just the parents, are you using paint or are you using solvent? This is a very, very wide group of potential chemicals. Some are water-based and some are oil-based, and of course the composition will be different. Petroleum solvent, those are the the trigger in terms of the question that we ask, but this is the best we're going to get when you are going to interview families. In terms of what we know of the carcinogenicity of paint and solvent, most of it is derived from occupational settings. Little is known in terms of the risk that you could face if you use it at home. So most of the classification in terms of being a human carcinogen derives from those studies. So what we have found in our data, and that was based on about 550 ALL, and now we reach about 800, and we are in the process of renewing those, updating those findings. But we found a striking contrast between paint and solvent at that time. I'm losing the laser, sorry about that. If you look at paint, we found about a 60% increased risk associated with childhood ALL, and the use of paint, as a broad indicator. Here, when the use of at that time, solvent didn't seem to increase the risk. In terms of time windows of exposure, it appears that using after birth was driving the overall risk. When we looked at those subtypes that Joe described, and we were hypothesizing that there will be differences between TEL-AML and hyperdiploidy, and we were able to identify, based on the very small numbers here, that most of the risk was driven by this TEL-AML subgroup. So that was a first indication that there may be very specific etiology according to the subtypes you're looking at. When we turn to AML, the second common group of childhood leukemia, although much rarer, it's about 15% of childhood leukemia, then the picture was just the opposite. We were finding excess risk with solvent but not paint. And most of the risk, again, seems to be driven by postnatal use of solvent, of solvent, I'm sorry. So what does it tell, what are the conclusions of those? Other studies have looked at paint and solvent, but only few of them in the United States mostly, and it has been, again, inconsistent. 2 of them show an increased risk, and 2 of them don't show an increased risk. So we are a little bit left with the only tool we have for identifying exposure to paint and solvent, which is just self-reports. So that may be a dead end for this type of exposure in terms of analyzing the risk. I'd like to turn to pesticide now. As noted before by many speakers, we're not just talking about one type. There is many different compounds that are included in this broad term, pesticide. About 800 active ingredients have been registered in the US. It's pretty much impossible to assess the carcinogenicity of all of them. And again, we're pretty much left with little characterization in terms of carcinogenicity as a whole when we look at the IARC monograph that tends to give us an idea of whether or not it's a carcinogenic compound. So those studies do not cover the wide range of compounds that children could be exposed to. There has been a lot of work in terms of trying to characterize the risk of childhood leukemia and ALL, because this is the most common subtype around the world. And this is a cartoon that shows recent metadata analysis, like a lot of scientists seems to be doing these days, just to have an overall feel of what's happening. And the use of insecticide at home during pregnancy and during childhood was consistently related with the excess risk. I mean, there's a lot of different methods used for selecting cases, for selecting controls, for doing the interview, but overall, all those methods that have been used across, different countries have pretty much come up to the same conclusion, that it seems that there is a risk associated with the self-report use of pesticide. So we have conducted the same studies and analysis here in the California Childhood Leukemia study. And if we go by the main group of pesticide that we asked the parents to report on, you can see that in this group of indoor insecticide, including this professional pest control that Joe was mentioning before, we can see that most of them seems to convey an excess risk that goes from 1.4 to 1.56. When I move to outdoor herbicides, with a very loose definition in terms of professional land services, they may be using herbicide, they may not be using herbicide, but that's what we get. We also find some excess risk, to the range of 1.3, 1.6. When we look at any other type of outdoor pest to control mice and rats and other disease, here there don't seem to be any type of any risk associated with that. So overall, if we combine those groups that are very broad anyway, it seems that there is an excess risk with indoor insecticide, outdoor herbicide, and nothing with outdoor pesticide. Well, the next phase is to look at the time window of exposure, who is using it. So the complexity with this data is that we run very fast into correlation. I mean, somebody who's using prenatal, he's likely to use it postnatal. I mean, those are heavy users versus low users. So when you start to look at many characteristics of the use, you run into high correlation, multiple comparison, and you don't know what is your baseline. I mean, who are the non-exposed? I mean, this is very confusing. Potentially, one may say, well, those are the same people. They're pretty much, using a lot of it, and you're not able to pin down specifically a compound. I think this is what we're facing with this type of data. So the approach we took was to try to use some statistical technique that can summarize the characteristics of use of this pesticide in terms of how much they're using, what type they're using, where they're using it, and the timing of use, to come up with non-correlated factors that we can trust, that will tell us something for what they are and not being accounting for any other aspect. So when we use this technique of reducing the data into independent factors, we were able to identify that the time window of exposure out of any characteristic is the primary predictor of the risk, and that any other characteristic, even the location being in or at, is borderline, but the main characteristic is when you use it during pregnancy, where the risk is much higher. So this is a cartoon, that cartoon illustrate what I was saying, and I will have to update that with our more recent data, but there is a risk associated with prenatal and postnatal exposure to pesticide. All of them are above 1. However, it seems that the risk is higher when you use it at least during pregnancy. So that may be the most we can get out of self-reported data in terms of information on the time window, because that type of source of information doesn't allow you to pin down what type of pesticide you will be talking about. So what we've done to try to understand what type of pesticide are being used and could be associated with risk, we actually went back to those a subset of houses and looked under the sink, in the garage, everywhere in the house, to try to actually collect all the pesticide product and record the EPA registration number that is on every single product. And we were able to go back to 500 households, pretty much split between cases and controls. We were able to identify there was at least one pesticide product in 98% of those houses. Once we had the US EPA registration number, we were able to actually identify over 2,000 products overall out of those 500 houses. And we were very successful to link this recorded EPA registration number to the database on pesticide product information system that is publicly available. That was a very successful linkage. But 93% of the product that we had recorded in the houses were linked to this database. And when we look only at the control homes, because it is believed that parents of children that are sick may be more likely to change their habits, and they may, toss out the pesticide, they may clean their house much better. So we looked at the distribution of the most common active ingredient in the control homes as a possible more representative sample. And there's no surprise here that the one that we find are the ones that are most commonly used. So this helps us to support that, yes, self-report will not give you an information on the type of pesticide. However, if you are not sure about what type of pesticide are used when you look at the cell product, you can still find those in their house. So it helps to bring some support to the finding from the self-report. The next route of assessing exposure was to use the dust. And Todd talked about some of methodological issues yesterday about the dust sampling. And I will just stress again that the dust looks at not only the use in the residence, but also can account for any take-home from the parental workplace and any drift from the areas that are highly agricultural, like the Central Valley where we are in. So this is still a very, very precious media to try to assess pesticide exposure. Well, I'm going to focus on herbicide. That's the analysis that I was doing, and colleagues at the National Cancer Institute are also working on the insecticide one. But those were the 17 herbicides that we measured, and you will see in red the ones that were highly prevalent and detected in more than 50% of the houses. In blue are the ones that were just in the middle. And there was a lot of them that are mostly agricultural that were not detected in our house. So we were pretty much left with actually little numbers of highly detected herbicide. Out of that list, only those who were at least 5% detected, only one stood up. That was Dacthal. Dacthal, if you look at ever detected, yes or no, was showing a 1.5-fold increased risk, significant. And there was some indication that as the level were increasing, the risk was increasing. That's the only one that stood up. There is no other herbicide, no other insecticide that have been found to be elevated, associated with an increased risk of childhood ALL. Dacthal is interesting, however. I don't think it can explain, a large contribution of childhood ALL. This is only one. But it's well known that the Dacthal product has a lot of impurity, and some of them contain dioxin. And everybody knows that dioxin is highly carcinogenic. So whether or not it's the parent compound of Dacthal or the impurity at the time of the manufacture that are involved I don't think we have the answer, and this is the first report that will be ever shown here. So I'd like to kind of raise some issues in terms of where are we now in terms of assessing the risk of childhood leukemia and pesticide. Well, when we look at self-report around the world, I'm talking about studies in Canada, in Brazil, in France, I may be missing Germany. There is a consistent report about increased risk. No specificity in terms of what are the agents, but fairly consistent that in utero exposure will likely increase the risk of leukemia. In terms of compound, we were kind of disappointed in a sense that all the work we've done with dust has just been mostly negative for pesticide. And the reality is that in contrast to some of the organic organochlorine compound PCBs that are really persistent, like I'm talking about decades of persistence, well, those pesticides are, persistent within weeks or months, and that the drift in of those pesticides from outside, may not support to be reflective of what was the exposure at the time of real time window of interest. So I think we're still facing a lot of methodological issues when you use the dust. You have to be very precise, maybe in the analyte that you're going to be looking at, and those that are not that persistent may not come up in your analysis. The second point is that we always rely on people willing to participate. So the first batch, the first group where everybody enters the study, well, we know that they will be more likely to be high SES for the controls than the cases. And then when you ask to go back to their house to do additional monitoring, well, you have another selected group of subjects. So these groups may not be representative of the whole population and may have very selected characteristics, so that you are not able to generalize what we find from the subset for which we have dust versus the overall. So I think we're still facing some challenges in terms of characterizing the risk. However, depending on what you want to achieve, if you want to achieve and understand what are the exact mechanism of which pesticide will cause which subtype, well, this type of traditional epidemiology will be an end to it, because I don't think we can go more than what we have been doing. Now, in terms of if you want to give some recommendation, and yesterday there was a nice talk about, what do we know in terms of evidence, and if it's easy to not to use and recommend of not using pesticide during pregnancy and early age. That's an easy reach, and maybe we have provided enough evidence for that. So I think depending on what's your goal, this type of data will be used differently. And I wanted to finish on this comment that I was making about the persistence of most of those pesticides that are not organochlorine and organochlorine compound like PCB. This analysis was done, using dust data from the subset that I've talked about. And the analysis was able to show that, yes, there was an increased risk with overall PCB levels, and that the risk seems to be increased with the amount of PCB level in the dust. So this type of compounds may be more robust to dust sample than pesticide is. And of course, there is no other efficient way to characterize PCB using self-report. I mean, the source of PCB is so wide that a questionnaire will never get at it. So I think I want to balance back to the fact that dust samples has a value, but it has to be very selective in terms of the compound you're looking at and the time window that you are also assessing, like Todd was saying. After 7 years, you may run into trouble if you want to rely on dust for a retrospective assessment of exposure. And of course, we have a lot of clinicians to thank, because without them, we would not even start the study. They're the ones to be in contact with the family at the time of the diagnosis, which is a very, very difficult time. Leukemia is a rare disease, but it's very devastating, as you can imagine. And there's still a lot of complication of the heavy treatment. And I would like to thank our sponsors, EPA, NIHS, and NCI mostly.